Today we'll be focusing on doing some neuroanatomy on the limbic system, which is, as you'll see, related to our presentation topic by Dr. Kleen, Introduction to Epilepsy. Again, we'll start off with a few definitions that I think will be helpful for these talks, and then we'll hop right into limbic system functions. I'll discuss some of the structures that are related to the limbic system, including the hypothalamus, olfactory bulb, hippocampus, amygdala, and then I'll also talk about how the limbic system is involved in different neurologic diseases. Just to orient you to ventral and anterior, which refers to the front of the body, as opposed to dorsal and posterior, the back. Rostral is anything that's closer to the head, and then caudal is anything closer to the tail or the lower back. And then a few new terms. When we image the body, we have different planes that we can image in so that we can get a 3D, good 3D view and reconstruct it in our heads. A horizontal plane is also called a transverse or axial section. And then a cut through the front of the head, like a crown, is a coronal section. And then down the middle on the side is known as a sagittal section. And we'll be using these terms to describe the anatomy today. Okay, so the limbic system, limbus means ring, and the limbic system really refers to a ring of different both cortical structures and the structures sort of below the cortex that form a ring around the top of the brainstem, which we talked about last week. The limbic cortex is part of the oldest part of the cortex in terms of evolution, so it's been around for the longest period of time. And in blue, you'll see the different parts of the cortex in the different planes. Again, the sagittal plane, and this is looking from the bottom, the ventral surface. And so this is sort of an axial view, and then this is a view from the side. The limbic system controls homeostatic functions, so neuroendocrine and autonomic function of the body. It also is tied with our sense of smell, olfaction, memory. It's very much a key structure of memory, and then also a critical structure in how we process emotions and what determines our motivational drive. This is just a schematic of how complicated of the few structures in the limbic system are. They're all interconnected and interrelated. So we'll be focusing on olfaction, the hippocampus, amygdala, and the hypothalamus, but really these have a lot of crosstalk, not just with each other, but also with the limbic cortex, and then different areas and tracks that connect the limbic cortex with these other structures. And then they also have crosstalk with the brainstem that we discussed in the spinal cord for the last 2 weeks. First, let's talk about the hypothalamus. It is the hypothalamus, so it's underneath the thalamus. It really controls so many parts of the body we take for granted. The autonomic system, both parasympathetic, which controls digestion and sort of quietness, and then the sympathetic nervous system, which is our classic fight or flight autonomic system. The hypothalamus is also important for regulating appetite, thirst, temperature, sleep, and circadian rhythm, and it really controls all the hormones that are produced from our pituitary gland, which control growth, reproduction, and metabolism, and many more, too many to list on here. But it is an important structure. It is thought to be can be affected. And when it isn't affected, it can really have a large effect on people. It's thought to be involved in eating disorders. It can also be involved in seizures. And then many think that it's important for headaches as well. Olfaction is really tied to the limbic system, so I thought we could go over it today. The olfactions, our sense of smell really starts out at these olfactory receptors that are along our nasal mucosa and the nose. And these neurons, receptor neurons, sensory neurons, come in through the cribriform plate, and you can see these are little tiny holes in the skull. And they synapse onto neurons in the olfactory bulb. So you can imagine anytime someone has a traumatic brain injury, these neurons can be sheared very easily. And so that's why people often lose their sense of smell after hitting their head, because these are just cut off based on the shearing force of the fall. Then the neurons in the olfactory bulb, they synapse into different nuclei and project into different cortical regions, including the entorhinal cortex, which we'll hear about later, the basolateral amygdala, and also different olfactory auras and areas. Next, let's talk about the hippocampus. This is a key structure that's involved in memory. It's although very complex, it's known for its sort of structured, ordered circuitry. And the hippocampus is really the area where we came to form our understanding of learning and memory. So some key early experiments in the hippocampus showed that cells that wire together also fire together. So the more you stimulate two cells in sync over time, the more likely they're able to form a stronger connection. And this is known as long-term potentiation, which is a form of plasticity. And plasticity is a term that we use to describe how the brain is able to change its connection. So even though we don't think that neurons new neurons aren't growing and forming all the time, we do know that neurons actually make connections with each other that are decreased or increased over time. And this is termed long-term or short-term plasticity. You can kind of see here's an old experiment that was done in the hippocampus where they stimulated a set of cells in the CA1, and then here they gave a very strong stimulus to a group of cells. And then after the strong stimulus, they see that the cells tended to fire more together and have a stronger correlation. And the hippocampus is this sort of jelly roll-like structure here. But you can see it also is very long in the sagittal plane, so it's kind of like a tube. I should also say that the hippocampus makes connections here with the entorhinal cortex, which is part of the limbic cortex. And through its connections to the entorhinal cortex and other parts of the limbic system, really is thought to play a key role in memory formation. And we'll talk a little bit more about that later. The amygdala is an almond-shaped structure. It's involved in also memory making and making decisions and choices. It's also critical for different emotions, particularly fear. Damage to the amygdala, if both sides are damaged, that leads to sort of tame, less aggressive behavior, although people or monkeys, which is what it's most studied in, can become hypersexual. There can be some compulsive eating behavior and loss of fear sensation. On the flip side, stimulating the amygdala can lead to overexcitability, rage, and fear. The conditions where the limbic system is really affected include conditions like seizure, which we'll hear more about from Dr. Kleen. I just wanted to put this up here. Seizures are uncontrolled electrical disturbance in the brain, and depending on where the seizure activity originates, it can cause different auras, movements, actions, loss of consciousness. But these are just intracortical recordings where there's electrodes placed just overlying the brain. And you can see here, this is right where the seizure starts in this area. You can see this pattern that's changed from before. And then you can kind of see it spreading in different electrodes to different areas of the brain. And then here, by now, 10 seconds later, the brain activity is way out of control. And you could just see these dark lines where the activity is going haywire. And this is sort of a schematic, which was actually developed by Dr. Kleen, where you can see where the seizure is originating and how it propagates in space and time over the brain. Another thing that can happen in the limbic system, so people who have refractory seizures, sometimes we need to remove that tissue that's propagating the seizures. And a famous case of HM, which we'll also hear about later, he had severe refractory seizures and had surgery to remove both sides of the hippocampi and also the medial temporal lobe structures. And his seizures definitely did improve after the surgery, but then he could no longer form memories or remember new experiences after 5 minutes. So he could repeat things that you told him right away. So he could register what you were telling him. His intelligence remained the same. But after 5 minutes, he couldn't remember anything, even if you gave him hints. His remote childhood memories were intact. He could even learn some motor tasks and get better at them, but he didn't remember ever learning them. The limbic system can also be affected in different conditions like infections with different viruses, or can be targeted when the brain produces autoimmune antibodies against itself that can target the limbic system. So here you can see lighting up of the hippocampus, which we learned about earlier, and then also the surrounding temporal lobe structures. And when viruses or antibodies related to cancer or just antibodies that the body makes on its own affects this region, it's known as limbic encephalitis. I also put down cancer like lymphoma or glioblastoma. Cancers can also affect these limbic structures, and then you could also have strokes that cause deficits. And this is more of a, instead of these, which is more of a slower process, with stroke, it might be more immediate. With cancer, it would be gradual and progressive. Okay, so that's a short overview of the limbic system. These are the references, unless I had made notations in the notes. And today I'm particularly excited to introduce Dr. Jon Kleen. He specializes in epilepsy care. He's an active neuroscientist here at UCSF who uses signal processing to study diagnosis and treatment of epilepsy. He got his PhD and MD in PhD in neuroscience and MD at Dartmouth School of Medicine. And then he came here to UCSF for residency and completed his clinical and research fellowship here. So he'll be showing us some of the new technology that I previewed, where he developed and programmed how to map brainwave recordings onto brain images to help really pinpoint the origin of seizures. And his lab also works on very basic questions about how electrical impulses are propagated over areas like the hippocampus and how they might reveal to us how information is processed in the hippocampus and how it might be networked. And so he's doing very exciting stuff. So, and he'll be talking to us about just give us a broad overview of epilepsy and some of the newer developments in the field over the past couple of years.
Great, thanks for that wonderful intro, Dr. Waung. And Dr. Waung was one of my people who trained me back when I was in residency here. So I really appreciate being able to work with her through these years too. It's been wonderful. But yeah, I'm very excited to be here. This is great. So having a lot of people interested in neuroscience and neurology, this is fantastic. It's the place to be, I would say. And so I'm going to talk to you more about epilepsy primarily, and kind of talk about some of the history of things, and then a pretty wide overview of the newer sorts of forms of treatment that we have and the way that we're trying to understand this condition. So, but what is epilepsy? We've all probably heard of it, right? But what is it exactly? So it's a neurological condition with recurrent unprovoked seizures. So recurrent meaning they happen more than once, and then unprovoked meaning sort of spontaneous, not due to something directly at that time. So, but what are seizures? So seizures are paroxysmal, meaning sort of sporadic or randomly occurring, stereotypes, meaning very consistently the same, spells of altered movement or sensation or experience or consciousness. All of these different things are a possibility for seizures, and but the key part is that they all result from excessive electrical activity in the brain. Okay, so epilepsy being a condition where these recur for someone over time. How common is it? We've all hopefully heard of it. It's actually the fourth most common neurological disorder behind migraine, stroke, and Alzheimer's disease. So it's pretty common. It's actually 1.2% of the population. That means over 3 million people in the United States. And so you probably may know people with epilepsy, considering that 1 in 26 people will develop epilepsy at some point in their life. Not that, so 1.2% of the population have it at a given time, but 1 in 26 will develop it at some point, whether it be in childhood and then hopefully it coalesces and goes away, or don't have it throughout most of their life and maybe it comes later on. But yeah, pretty common. So we talk about seizures, and that's technically the definition, right? But they are actually just one symptom of epilepsy. There's a lot of other things that occur for people with epilepsy. We call them, a lot of them can be called comorbidities. So conditions or issues with health that happen in parallel with epilepsy. And these consist of things like psychiatric disorders, such as low mood or depression, anxiety, cognitive impairment. It's a big interest of mine, is memory loss, even just word finding difficulty and sleep disturbances, but plenty of other things too. So injuries and accidents due to the seizures. The medications themselves can cause side effects depending on which ones and how high of doses they are. Other diseases may put people at risk, higher risk for obesity, stroke, hypertension, or high blood pressure, and bone disease, and then even mortality. So unfortunately, due to injuries and accidents, but even just what we call sudden unexpected death in epilepsy, and even suicide rates can be higher. So this is a very important condition to be looking at, not only just for seizures, but for everything else that can happen with patients with epilepsy. But what causes it? So is there just like one straightforward cause? Of course not, right? There's actually many causes. And one thing that is increasingly known now is that there can be a genetic predisposition to epilepsy. Sometimes there's a mutation in a single gene that can cause epilepsy in a given patient. But a lot of other times it might just be a predisposition. So maybe there are a couple of genes that might put somebody at higher risk to get epilepsy. But there are many, many other cases of epilepsy where we have no idea what their cause, or they have a completely non-genetic explanation. So head trauma or injury to the brain, and similarly strokes causing injury to the brain, infection, same idea, brain malformations. These usually mean things that happen during development of the brain early on that end up giving altered anatomy of just one or a couple of different areas. And these areas can be irritable to the brain and generate seizures. Similarly, for tumors, sometimes it's the first presenting symptom of a new brain tumor. And then neurodegenerative diseases such as Alzheimer's disease can show higher rates of epilepsy as well. But it may seem like we have all the answers here, but certainly we don't. A cause is never found in over half the cases. That number is kind of getting smaller now as we uncover more about genetic predispositions and other disorders, but still there's quite a few people where we unfortunately can't give them a good explanation at this time yet about why they developed epilepsy. So how do we diagnose it? It's actually what we call a clinical diagnosis, where I really just need to hear the story about what someone describes, certain events that either they experienced and remembered or have sort of details about, or that their family members may have seen or a friend. And even just the things that they say, the way they describe it, there are certain key characteristics of seizures that we can pinpoint really just from hearing the history from what someone describes to us about this. But there are a lot of other options though too. In particular, we can use MRIs. So this is like a really strong, a great imaging study that uses really powerful magnets to make images of the brain. And sometimes we can find a cause that would explain why someone's having these symptoms that could be seizures. That's helpful to us, especially if we're kind of on the fence about whether this is epilepsy or something else. And I'll talk about what we call a differential diagnosis or other potential explanations in another slide later on. And then EEG is also extraordinarily helpful in many cases, but certainly not all. This is a brainwave test, so I'll just describe it in a moment here. But actually, if I take 100 people that have epilepsy for sure, and I give them an EEG, only about 3/4 of them, if that, will have an abnormal result on the EEG. So it's not a perfect test because it'll actually miss some cases of epilepsy. And really, that's why it all kind of comes back to the history. Just knowing a lot of different ways that epilepsy can present itself, seizures, and risk factors as well. Those are the key things that we need to diagnose epilepsy. So I mentioned EEG. Let's kind of get down deep into this a little bit because it's actually a really neat test that was developed about a century ago. And now with new computational methods and data-driven initiatives and just computer science in general, we're able to look at EEG in whole new ways now. But it all boils down to the first EEG that was obtained by Hans Berger, professor in Germany back in 1924. This is the actual, one of the original recordings. So this is the brainwave trace on the top here. It was drawn by a pen that was being moved around by the voltage changes from an electrode in the back of a person's head. And then below it, he shows like what a sine wave would look like at about 10 hertz, just showing like what we would expect for a perfect cycling sine wave, just to show that the brainwave is actually creating cycles of activity. And that was called the alpha rhythm because it was discovered first. So and it was measured from the back of the head. And we see the same rhythm today in EEGs. It's one of the key things that we look for right off the bat to say, oh, there's the alpha rhythm. So that was the first EEG almost a century ago now. But that was one electrode, actually technically two electrodes, because to measure it, you have to take the difference between two electrodes. But people were doing EEGs sort of in different ways for a couple of decades. And then finally they said, you know what, we need some standardization. We need to have an EEG put on the same way for everybody each time so that we clinicians can talk to other clinicians about where things are coming from, and researchers can talk to other researchers about the same, and so on. So they created this system called the 1020 system. And it's basically measured distances between anatomic landmarks, like the right on the top of the nose bridge there, to this little bump in the back of the head. And they take percentages of the distance and they put electrodes on those spots, as you can see over here in this. And it gives you, and you have like names too, the odd numbers are on the left side, the even numbers on the right side. And you can see that those electrodes now are representing these brainwave traces on this screen. So this is still what we use today, actually, the 1020 system that was developed in 1957. It's completely standardized, which is great. So I kind of described a lot of this now, but an EEG itself is electrodes temporarily pasted on the scalp. But we have trained technicians that do this all the time at UCSF, actually one of the biggest centers in the West Coast. So we have a lot of EEGs going on, but they temporarily paste these electrodes on the scalp. Here's just an example of one pasted right behind the ear. But they put them all over in these different spots that I just showed you. And then we get these squiggly lines, kind of like you saw before. And But yeah, the key part is that it's standardized so that when we look from patient to patient, we're able to interpret things much more quickly and know where they're coming from on the brain. Okay, so this is just an example of normal background activity. We call it background, just like your background regular rhythms that we would expect about things. And just of note, this little blip right here where all the electrodes are kind of moving down at once. That's actually an eye blink. So it doesn't pick up just brain waves, it picks up other things like eye movements because there's a bit of an electrical field in our eyes, if you can imagine that. But once that happens, the person's actually closing their eyes and then the alpha rhythm comes out. And so it's kind of neat to see the same thing that that doctor about a century ago saw at that point, we still can see today very quickly and readily. And so moving on from a normal EEG, this is actually an EEG with a seizure. So in the very beginning of this, you can see this sort of dark activity. That's actually muscle activity. So again, not just brain activity is picked up, but even muscle activity. But then once this kind of goes away, or recedes, we see this sort of choppy, sharp activity across pretty much all the electrodes, but especially the ones over the left side. These are on the left side of the brain, all these here, and these are on the right side of the brain, these over here. And they all look a little bit abnormal or kind of choppy and sharpened, but it's stronger and larger in amplitude or larger in size over the left side. So that's a left temporal lobe seizure. With EEG, we can, I just mentioned it's a left-sided seizure versus a right-sided seizure. We can even get down closer in terms of where we localize things, meaning where we find the focus to be. And a lot of times seizures are actually caused by a single focus. And what is that caused by? I mentioned some causes before, but I want to just kind of go into structural causes of epilepsy. So I mentioned tumors and such, but there are a lot of other structural causes. These are all different conditions. So polymicrogyria, focal cortical dysplasia, these are developmental symptoms or developmental problems. And then, these conditions here, heterotopic gray matter. We also have vascular malformations or, basically, and then epilepsy associated tumors. So ganglioma in particular and DNETs. And then, so they're a very long name there for that one. But one thing we often look for adults with especially new onset epilepsy is not necessarily all these things. These are usually, they're more rare, they're picked up usually pretty early for people with these sorts of issues. What we find in adults, actually the most common adult epilepsy is temporal lobe epilepsy. And it's the signature of that, if there is one on MRI, it is mesotemporal sclerosis. And that's what you see right here. This little section is the hippocampus, as Dr. Waung pointed out. And over here on MRI, there's that hippocampus again. And this special sequence of MRI gives us a bright spot where it's abnormal, and that's the hippocampus right there, lighting up. So I'm mainly talking about focal seizures. And focal seizures essentially start in a single focus, but then they can cause problems by not just, abnormal activity there and affecting whatever is supposed to go on in that brain region, but then by spreading to other regions. They might spread a little bit and then stop, but actually, in worst cases, they spread and involve an entire hemisphere. So this is a focus right here, and the seizure would start in this section and then start to spread to this cortex. It can actually spread to involve the entire hemisphere and the opposite hemisphere. So that's what we'd call a secondarily generalized seizure. And these are usually associated with falls, injuries, and a very strong the picture in terms of what the seizure looks like. And the recovery is also very difficult from those. We can also get primary generalized seizures. These tend to have more genetic causes to them, but this is where the seizure kind of starts everywhere all at once. And there's conditions such as absence epilepsy and juvenile myoclonic epilepsy. These are associated with generalized seizures, which kind of start in both hemispheres in really broad areas of the cortex at one time. So again, focal seizures or localization related seizures that can secondarily generalize, and then primary generalized seizures that start kind of everywhere at once. So I wanted to give an example case, and this is actually a patient that I saw back in residency. And I saw this person in the ER, and they said to me, "So doc, I don't remember driving home." And I was like, "Oh, that's the symptom?" It's like, that's it. But it's a really big problem because, and then he kind of elaborated a little bit. So what happened is, I can go through this a little bit more. Just, a young male presented to ED, ER, describing an episode of amnesia during which he actually drove home successfully. So this was immediately preceded by a feeling of deja vu and right-sided headache. Essentially, he went out to dinner and then dropped someone off after that, and then got in his car and backed out of that person's driveway, and then all of a sudden found himself in his home in the parking space with a scrape on his bumper. And so he actually called 911 immediately after that. He took out his phone when he realized that he was just home and there was no answer for what had just happened in that stretch of time. And the ambulance came by and he explained the story to them, even though he looked fine at the time. But they were concerned too. I mean, this would be concerning to anyone. And they brought him to the ER, and that's where he told me this symptom of I don't remember driving home, which is obviously a very significant event in this case. So, and just to kind of put that in context here, no memory of driving home, but that's not just a simple like event, right? It's actually very complex, a lot of complex things to do. So he was able to drive along the route all the way home. He actually used a mapping, he always uses like a mapping sort of device that kind of shouts out the directions to him. So he followed the usual route home, but even some extra directions that he had to go. He was able to punch in the code for his parking structure, and then able to park in his specific parking spot. And then it's only after he got out of the car that he realized that he didn't have any memory of all these things. So how could this happen, and what would cause this? I mean, the name of this lecture is, of course, Intro to Epilepsy, but just to describe some other things that it's important to think through, there are a lot of different causes of transient amnesia, transient meaning temporary. On the order of seconds to minutes, you can get the transient cognitive impairment due to actually epilepsy, but it's really just due to a really short burst that will happen, a hippocampal spike, for example. And on the order of minutes, things like low blood sugar, hypoglycemia, a very, very short seizure, which this sounds like it could possibly be, or on the order of hours. So alcohol, drugs of various sorts, migraines can potentially do this, post-traumatic, if someone gets hit in the head, they may get knocked out for a little while, non-epileptic or psychiatric causes, and transient global amnesia, which is kind of this whole separate diagnosis of just an amnesia period, but not necessarily associated with seizures in most cases. And then even transient ischemic attack, which is thought to be a vascular cause. Dr. Waung mentioned limbic encephalitis, which is on the order of days to weeks, really, that someone would have amnesia. And then months, years, or lifelong can be things like hippocampal stroke, or Wernicke's encephalopathy, or even dementia such as Alzheimer's disease. So there's a lot of things that can cause your memory to go down and be dysfunctional for a while, and just your memory, whereas the other functions of your brain are still relatively intact. But this one was pretty compelling for a possible seizure. And we had an EEG done for this patient. And on this one, the blue traces are on the left side, just to help orient, and then the red traces are on the right side. The rest of these are just other areas kind of around, and there's an EKG there. There's also to look for eye blinks, these eye electrodes nearby the eyes. And so on this EEG, we actually saw a spike. That's a burst of activity, and it was over the right temporal area, the right temporal lobe. And then we saw a couple more examples of this. This is an abnormal sort of waveform to have in your EEG. And so that helped us kind of boil things down to, that this is probably a seizure, and it may be one that's affecting the hippocampus because of the amnesia period. Hippocampus is very involved in memory, especially ongoing new memories. And then also he mentioned, I had deja vu right at the beginning of this. I just felt this feeling like I've been there before. Many of you, maybe all of you, have felt deja vu before, and I don't want to cause any alarm. The incidence is really common, actually. It's in 30 to 95% of people, depending on the study that you see. So it's not specific for epilepsy. But in the setting of known epilepsy, when you have something like this, where there was a complete period of amnesia and other potential risk factors, that sort of disturbance of those memory systems could be consistent with a medial temporal lobe or a hippocampal onset. And this is just a picture showing the hippocampus in red and the entorhinal cortex right next door. They talk to each other a lot, and activity between these two has been associated with that deja vu activity, even seizure activity for certain cases. Dr. Waung already mentioned the hippocampus. I've mentioned it a couple times. It's actually my favorite brain structure. because it's just so interesting. And it's a really strange word, though. I don't know if Dr. Waung mentioned this, but the word hippocampus actually means seahorse, because some anatomists a long time ago thought that this structure looked like a seahorse in the brain. You can see it there. And it's been around evolutionarily for a long time. So in the rat, that's kind of what it looks like. It's more curved towards the top of the brain. In a monkey, it looks a little bit more like ours, but even ours is extended even farther forward and sort of trimmed down a little bit. So it's been around for a long time. And that's really important, actually, because you might be wondering, well, why do we keep talking about the hippocampus? Why is it mentioned in the context of epilepsy a lot? It's technically old hardware. Think of it like a computer. You're using old hardware, or what's called paleocortex, paleo meaning old. And through evolution, more and more cortex was stacked up on this old hardware. It's interfacing with it because it does this incredible thing, which is our memory system. We have a time machine in our brain. We're able to think of pretty much any memory we want to just go right there in our minds at that moment. And this can be, of course, disrupted in certain conditions. But still, like, the fact that we can do this is pretty incredible. But there's a lot of really neat things that humans can do, advanced language and all these other things. But all this is stacked up on a memory system that does a really magical thing, but it's still old hardware. It's it's one of the only places in the hippocampus, in the brain, that has 3 layers. The only other place in the human brain that has 3 layers to it is the piriform cortex, which is important for smell. But the rest of the cortex has 6 layers. So stacking up all this new machinery on old hardware could potentially predispose it to just being overwhelmed at times. And it's got really high density of what we call excitatory receptors, and so NMDA receptors. I think Dr. Waung mentioned those. So there's too much excitation. This structure is really prone to being scarred and to develop epilepsy and seizures. So, I mentioned that. So yeah, I mentioned temporal lobe epilepsy and the most common adult epilepsy that we see. And seizures originate from the temporal lobe. It's not always the hippocampus, but it commonly is, for the reasons I just mentioned. So hippocampal sclerosis is what we would usually see for a scarred hippocampus. And by scar, really, I just mean that it's been damaged for some reason. It could be encephalitis, it could be a stroke or hippocampal stroke, or it could be just spontaneous. We don't really have a reason at this point. This is what it looks like microscopically. This is a normal hippocampus. You can see these really nice layers all organized. And then this is a hippocampus with sclerosis, much less organized. A lot of it is really not even present anymore and damaged down. Okay, so I've talked a lot about, I've talked about an example of epilepsy and the different types of them. Well, what do we do about them? We treat them with medicines, right? There are a lot of medicines for epilepsy. There's like dozens of them, actually. Before 1993, even back in the 1800s, there was potassium bromide, which is not used anymore, except in maybe rare cases. But there are quite a few that were invented and put into practice before 1993. Then we had what's called the second generation here, up to 2005. A lot more medicines came on the market. And then we had quite a few more in the third generation, which is really from 2009 until now. And even in the last several years here, we've had 3 new ones added, including cenobamate just last year. So they all work by dampening or toning down abnormal electrical activity or the excitation. But the problem with that, as you can imagine, is sometimes we need activity. Well, we need, of course, brain activity to do what we usually do, think, to go about our day. So side effects of them often can be drowsiness, dizziness, and other things like rash and weight gain can sometimes happen too. A lot of medicines, which is great, but does that mean, especially with all these new medicines, does that mean that we can control everyone's epilepsy? Unfortunately, that is very far from the case. So I mentioned that over 3 million people have epilepsy in the United States. Well, this is just a way to show you 10 by 10 dots here. So there's 100 dots, and the dots that are blue show you, if each of these were people, the amount of people that would be seizure free with the first drug. So new onset epilepsy, you try a single drug at a really good dose, and how many do you get control of their epilepsy? About half, approximately. And if that first drug doesn't work, the natural thing is to try a second drug at a good dose. And of those, only another maybe 10% or 10 to 15% get control with the second drug. So then we reach a really problematic area. We try a third drug, of course, but really only like actually less than 5% overall of patients will get good, solid control of their epilepsy and seizures with a third drug after trying a first and second. So the rest of the patients really we call drug resistant, or used to be called medically refractory. But this is epilepsy that has not responded to 3 drugs. And the reason that we define it as such is because you see these diminishing returns, a lot of blue dots, kind of a good amount of green dots, but then few orange dots. And so once you try a 4th drug, you could imagine it's only 1 or 2 people out of the rest here would get control. So about 800,000 Americans experience seizures despite taking anti-seizure medicines. So this is a really tough problem, but that's exactly why we're here. And especially at big centers, level 4 epilepsy centers, this is really what we specialize in because there's a lot of thinking that has to go into it. What can we do to get better control of their epilepsy? Be it maybe another type of targeted medicine approach or other approaches. This is just another way to kind of show, before I mentioned all these different drugs coming on the market, this is time on the x-axis, dating back to the 1800s until about now. And then this is the number of new anti-seizure drugs. The point of showing this slide, it may seem kind of redundant, but the point is the percentage that are not seizure-free has been roughly the same this whole time. Like even now, with all these drugs at our disposal, we're only getting about, so it's like 68% seizure-free on drugs. So it really hasn't changed much. So you could imagine that even more and more drugs that come out later on, unless they have some wildly different mechanism, we're being a little bit realistic in terms of the likelihood that they're going to help. So we'd like to talk with those patients about other possibilities. And I'm going to mention sort of epilepsy surgery as one. And part of epilepsy surgery, though, would be, well, what's the point of it? It's if seizures are coming from one specific spot in the brain, and that seizure focus area is not doing any good for the person besides generating seizures, which is bad, should maybe take that area out. And as long as it doesn't overlap with an important part of their brain that they need, then they can actually get curative surgery. And this is one of the very few, actually practically the only curative solution for epilepsy is surgery. But we first have to really figure out where the seizures are coming from. So we use a combination of things I already told you about, the scalp EEG, really detailed 3T MRI. And then we use other really neat techniques called PET scan or positron emission tomography. This is where we have sort of a glucose or sugar molecule labeled in the bloodstream, and it can actually travel to the areas of the brain and distribute itself on both sides. But it tends to go to seizure focus areas less. And so we'll see like what we call hypometabolism or less signal in those areas. And then in terms of, I mentioned scalp EEG, but we can actually use not just voltage sensors, but magnetic sensors. So we look at the magnetic fields generated by the brain. This involves a bit of fancy physics, but MEG is magnetoencephalography. So it's this device that looks like a huge hairdryer, basically kind of pointing to someone's head, but it's got over 300 sensors on it. And it picks up electrical activity, and we can actually use that to map and pinpoint where the spikes and bursts of abnormal activity might be coming from. Here's an example where this little marker here is kind of pointing towards the right hippocampus for this person, where those were coming from. And actually, similarly, I'll jump over to this image here. This is electrical source localization. This is actually very similar to what I just described for MEG, but we use the scalp EEG electrodes. We can actually take this data here and give it to someone who knows how to do this, such as my colleague and friend, Dr. Robert Knowlton, who is just a wizard at this sort of thing. He uses a lot of fancy physics, basically, to take these same signals and triangulate where the start of a seizure is coming from in the brain. Kind of similar to when you have your cell phone and you're looking on your GPS, seeing your position. That's triangulated from multiple cell phone towers around, or even satellites. And so the electrodes here are kind of acting like cell phone towers, and they're triangulating the signal where it comes from. And then finally, another technology we use is called a SPECT scan. So this is another study where we're injecting a labeled molecule, so it's got a radioactive label to it, but we inject it actually at the very beginning of a seizure. So a person would come in and stay with us in our inpatient monitoring unit, and we wait until they have a seizure and inject it right at the beginning. And it will go to kind of all the different places of the brain, but it will get picked up in the area that starts the seizure in a higher concentration. So then we can use some fancy imaging and hopefully pinpoint the spot where it came from. Ideally, all of these studies will align and say, there's the focus, there's your spot that you need to get. But a lot of times it's much more complex, as you can imagine, but still we are able to successfully localize quite a few seizures in people, and especially in particular drug-resistant epilepsy. But what do we do then? I mentioned epilepsy surgery, so where do these studies get us? Well, these are just a couple more examples of the source localization. Just wanted to show. It's really nice. It helps us map things in 3D that way with scalp EEG. So hopefully we can pinpoint just one seizure focus. So this is an example where, here's the brain, here's one single seizure focus. And then here's an example where you have a multiple seizure foci. So that's not a great scenario for surgery, which I'll mention in a moment. But if you have just one focus, that can be good. And I mentioned before how they can lead to secondary generalization. So if you can take out that bad spot and not cause any neurological deficits for the person, that's ideal. But also, since it will if you're preventing the seizure from starting, then you're of course going to be preventing it from going into a larger seizure. That can be a really fantastic thing for people, just being either free of seizures, or sometimes if we can't quite get it where they're free of seizures, hopefully they at least have a good reduction in seizures. Epilepsy surgery can be actually very highly effective. This is an example of what we might do for someone with right temporal lobe epilepsy. Usually the focus would be in the anterior or front part of the temporal lobe. And so we can remove this section of the brain, and we do some special techniques to make sure that the person would not have a neurological deficit or significant neurological deficit or problem if we take that out. But then if we remove the focus, then they would be cured. These curves down here just show you sort of the data behind this. So if you have time in months on the x-axis here, and then the total percentage of people without seizures, and you can see that basically it drops over time, particularly for people that just use medicines alone. But in the group that had surgery, they still dropped. There's still some people for which surgery was not totally effective, about half or a third of those that go through surgery. But they're quite a bit different than the people that just stuck with medicines only. Okay? So that's a huge reason why we recommend surgery in a lot of cases. Only after someone has tried multiple medicines, because surgery is not to be taken lightly, of course. It's only for people who have at least tried a couple of medicines first, because then we know that the likelihood of more medicines stopping their seizures is quite low. And similarly for children over here, similar curves with the surgery group doing much better than the medical therapy group. Oh, those are the numbers behind it in case everyone wants to look at them later. I think these slides will be available too. So how do we do epilepsy surgery? Well, it involves our surgeon, of course. Dr. Edward Chang is just an amazing surgeon, epilepsy surgeon. And we actually have the highest volume of epilepsy surgery on the West Coast, if you can believe it. But we look through a lot of really complex epilepsy cases, and many people are referred to us specifically because of drug-resistant epilepsy, for which seizure will hopefully help. But we do all these studies that I mentioned back here to try to pinpoint where the seizures are coming from, but we do it from outside the skull. In order to be really sure where they come from, sometimes we actually need to do what's called a intracranial EEG study. So think of EEG on the scalp, but now the electrodes are actually placed inside the skull, either on the surface of the brain or with certain probes, they get put into deep structures in the brain, because structures like the hippocampus are deep. And in order to record from there, these probes have to sort of enter and be placed there. Of course, this is just a temporary thing. The patients stay with us in the hospital while they're being recorded. And then once seizures happen, we're able to capture them on these electrodes and pinpoint the actual for sure focus where they're coming from. This is just an example of a brain here where there's depth electrodes, meaning these sort of stereo EEG types of electrodes. If I make it glass or transparent with some new kind of biomedical imaging techniques, you can see that each of these dots here is an electrode. And we were actually targeting this area of the patient's brain where there's sort of a scar tissue. It's called an encephalocele there. And that was likely generating their seizures, but we also want to be sure they weren't coming from the hippocampus. And that's what this electrode is here. I can blow that up a little bit. So the hippocampus in 3D now, we're looking, and I've got it embedded in a glass brain in its position. But you can see that these electrodes are coming through here, and the ones in the front of the probe here are sampling the hippocampal tissue in particular. And this is a really wonderful thing for confirming where seizures come from. You can actually confirm where they come from and then proceed, as long as it's safe, with a potentially curative surgery. So this is an example of intracranial EEG. And here we actually have spikes in the hippocampus. These are these same electrodes, and you can see this activity on these electrodes. There's a big sharp burst there, and that is very abnormal to have. And that area generated seizures in that same person later on. So very helpful, but you can already kind of tell looking at all these different electrodes that, boy, this is a lot of data to look at. And actually we have quite a few electrodes, and we end up looking at all these traces sort of page by page, 24 hours studies for usually several days. But it really kind of shows you the pattern, like once a seizure starts somewhere and it spreads across the rows of a grid, for example, and then eventually you have the seizure end after the spread. But yeah, the technology that Dr. Waung was referring to was kind of developed for this whole problem of, this is a lot of data to look at and to understand. And we want to be sure about what we're looking at. And so it would be nice to actually not only just look at this data by eye, but also actually have a helper software where we can plot it on the brain. Just say, okay, at this moment of the seizure, what does it look like as a heat map of the brain? So that's what that technology kind of was designed for. And here's an example of where this patient had quite a few electrodes implanted on the left side of the brain, as you can see. So a grid in this section, and then a little space between the next grid over here towards the back of their brain. All these black dots are actually electrodes, just to make sure that's clear. If I rotate this brain to the inferior or bottom side, that's what you're looking at here. So we're only looking at half the brain. This is the bottom of the brain, the temporal lobe here. Just like this is the temporal lobe here, we rotate it and now it's right here. So those are the electrodes that were on the side of the brain. And now you can see that we actually have electrodes in the bottom of the brain too. And then just kind of wrapping around this section. We like to make sure that we cover the areas where we think the seizures are coming from, and also so that we can watch where it spreads to hopefully understand why the person's seizures look like that, and to confirm that those are the seizures that they typically have at home. So that if we were to base surgery on the recordings, that we are being sure that we're targeting the seizures that they have at home that are causing problems. So just to play this video, actually I should pause it quick. This is the actual data here that we are always used to looking at. And then this little window here, whatever's in that window is going to get projected as a heat map over here onto the brain. So this is an 8-minute seizure, if you can believe it. The person's aura started, and aura is just like the first symptom of a seizure that someone might experience. This person's aura was a sort of twinkly light, sort of rainbow twinkly light in the right side of their vision. And we'll understand why that is soon, because the visual cortex is right back here. And so when the seizure starts, you can see that it actually starts right by this visual cortex area. And it's on the left side of the brain. And so it makes sense that that actually maps to the right side of the visual field. So this seizure is now spreading, and I shortened up an 8-minute seizure into 1 minute. So we're watching at really fast motion speed here, but you can see it's spreading now. And this is really what seizures do. They spread across the cortex. Even though the original area is now more quiet, it's actually spreading into the areas that are important for understanding speech. We call it Wernicke's area. So at this point, and I was actually in the room with the patient when this happened, the person was no longer able to understand me at this point, even though they were initially, because this area is supposed to help interpret speech. And then the seizure is now moving more anterior or forward beyond our electrodes, but it eventually takes over the speech producing area, so they become unable to talk at this point. And then pretty soon it goes into the secondarily generalization right here, where it's a really strong tonic phase, and then this jerky sort of clonic phase of the seizure. So then the seizure is done there. Again, that was an 8-minute seizure sped up really fast. And this, by the way, if anyone wants to see these, again, these are all on YouTube. They were, we published a paper last year. It's called, the technique's called ictal cinema or opsia, or OPSCEA. So this is another view of seizures here. This is actually a different patient altogether. This person had a grid over the frontal cortex here, and then the temporal cortex here. And then they also had electrodes sort of implanted underneath and also within as depth electrodes in the brain. And this one I'm going to kind of play in really slow motion, but I'm also going to rotate it so you can see things a little bit better, and where the seizures are coming from. So you can see activity kind of moving a lot of different places in the brain, right? We rotate this around to see another view, but you can see it kind of propagates or moves fast across the brain. But if you look, and I made this kind of a little transparent here, there's actually a really big hot spot here that keeps going this whole time. And it pretty much just kicks off activity that then spreads up through the front to the back of the brain. So this is a propagating seizure, but and we were really confused by this one. We thought there was actually multiple seizure onset zones, according to all the work that we did before they had this electrode study done inside the brain. But it turned out that they were all being generated from this spot here in the temporal lobe. It was, as you can see, kicking off activity that then just jumps up to that frontal cortex and propagates back. So in this patient, we ended up doing the surgery to remove the seizure onset zone after making sure that she was not going to have significant deficits, neurological deficits. And she's been seizure-free over 2 years. So it's a great outcome. And then this last sort of video I'm going to show you here is an example of, there's a lot of differences in how seizures spread. I showed you the 8-minute seizure that took a very long time, actually. It's a long time to spread, right? But this one, actually, I'm only going to show you a half a second of real-time data, but I slowed it down really slow motion so that you can see the details. Keep your eye up here on this brain. And actually, if I let this play a bit, these are just where the depth electrodes are. This section here, you can see the depth electrodes coming into the cross sections. But like I said, keep your eye on this brain up here, because if you blink, you might miss it. Unless you have to blink, please feel free to blink anyway. There it goes. So it started right here in what we call the posterior STG. It's just this gyrus here, the back part of it. But then it spread almost in an instant to a bunch of other areas, the temporal lobe, a bit of the parietal lobe, and also the frontal lobe up here. So really kind of an explosive onset of a seizure there. In these cases, we can usually help by removing the seizure onset zone, but it's not always the case. Surgery does have its limits. We can't just go doing surgery on everybody and think that we're going to improve their outcomes. Even if we were to stop seizures, what about other problems that surgery could cause? And surgery itself has risks, just like a surgery on your toe or anywhere else in the body. So we usually avoid surgery for particular situations, including when seizures arise from more than one place in the brain, especially if it's kind of bilateral, both sides in the same structure. And then seizures coming from brain regions that are just too critical to remove. So the areas of your brain that are in charge of language, for vision, for movement, especially arm movements, those are things that can cause massive disability for a person's life that would be permanent. And then also, if removal of the brain tissue would cause other significant neurological problems, kind of alluding to the point above it. And then, of course, some patients just don't want brain surgery. They just are too averse to it, and that's totally understandable too. But we always want to be really sensitive to that. But it's important to take in the context of how bad are the seizures too. If the seizures are really, really dangerous and they're causing falls that are causing injury, that's a really tough situation. If the patient doesn't want brain surgery, we want to be sensitive to that, but we also worry. A lot of us are just kind of constantly thinking about the patients like that, I can guarantee. But other times, if they're just small seizures and they really don't bother the person too much, maybe like once a month, they have a little subtle aura, but then it goes away. That person may not want a brain surgery, and that would make sense too. Totally understandable. And this is just an example of kind of, Dr. Waung mentioned this patient HM. So the name, after the person passed away a little over a decade ago, they released his name because he's the most studied patient in neuroscience, actually. This is the patient Dr. Waung mentioned where they removed both of his hippocampi because he was having terrible seizures that were thought to come from both hippocampi at the time. They also removed a couple other areas, including parahippocampal cortices, that's just area right by the hippocampus, the entorhinal, the piriform, which I mentioned before, and the amygdala. So after that, his seizures were under a lot better control. I think he may have actually been cured of epilepsy, but he was basically unable to retain any new information besides like sort of procedural memory or kind of motor sequences. But things like learning new people's names and such, like if you go into the room and then tell him your name and just say, nice to meet you, and then come back 15 minutes later, he wouldn't remember ever meeting you. So this is really profound. And this happened back in the 50s. It was a really important case driving a lot of what we do now to make sure that we avoid major problems with epilepsy surgery. Just a great example of that. But fortunately, this patient contributed hugely to neuroscience, especially to the understanding of the hippocampus. But you might be saying to yourself, well, it is 2022. I mean, we've got a lot of technologies now. Can't we just zap away these seizures? There's got to be something else, right? So what about those patients where we can't do surgery and the medicines are failing them? They've tried so many and they're not doing the trick. Well, wouldn't it be nice, like in cardiology, where they have not quite a pacemaker, but maybe a defibrillator, where a seizure starts, or just like an abnormal heart rhythm starts, and there's a zap, and then the heart goes back to the regular rhythm. So for brainwaves, that was the original thought behind one of the devices that is approved now called RNS, or responsive neurostimulation. It's a device that just kind of listens for seizures in the brainwaves, and then when it detects it, it zaps, and then hopefully the seizures have stopped after that. Indeed, people have been thinking about this quite a bit and pursuing the technologies, and there's actually 3 stimulators on the market now that are approved. I mentioned RNS just because it's got that idea of sort of responsive neurostimulation, just like in cardiology. That's one where so it's actually implanted with a depth electrode or even a strip electrode over the brain right at the seizure onset zone. So it's, when we are doing these intracranial studies, if we find where the seizure onset zone is, but we realize that we can't remove it without significant risk to the patient, or if there's multiple sites, like 2 different seizure onset zones that would have to be treated, that's where this can come in handy, because we can put the depth electrodes in these cortical strip leads right where the seizure onset zone is, and then have the neurostimulator device, which is really, it's a computer in a titanium case that is actually embedded right to the skull here. It actually sort of like a plate in the head, but it's actually a computer in there. And this device just sits there listening to the brainwaves. And then when it detects a seizure pattern, it zaps. And I'll mention more about this in a minute, but part of our job as epileptologists is to titrate that over time to try to target that person's individual seizures. And it's actually it's a pretty incredible time to be an epileptologist, increasingly so, because there are more and more people with these sorts of devices. And often people come into the office or on video visits, of course, and we'll ask how many seizures they're having. Still having seizures, we would adjust the medicines. But in these cases, and sometimes, and of course, it's usually both medicines and these, we also are adjusting the stimulators, saying, okay, well, it looks like based on your data that we need to get ahead of the seizures a little bit more. So we're going to adjust the pattern to target this part instead, or to this sort of rhythm. And then we change those settings, and then we hope that the next time that they come back for their visit, they'll be having less seizures. And it's a process over time, but it's just like medicines are. It's really a process over time. So that's responsive neurostimulation, where there's a lot of moving parts, but it's very flexible in terms of where you can put the leads. And usually we're targeting the seizure onset zone. And then there are 2 other options. Vagus nerve stimulation was actually the first neuromodulation or neurostimulation option for epilepsy. Came out like research mostly in like the 90s, in late 90s, early 2000s, it sort of came on the market and picked up momentum, and we still use it today. So this is where you're not actually stimulating in the brain, but you're stimulating kind of just this nerve that is highly connected to the brain here. So the computer part goes into the chest, just like a pacemaker would, and the lead goes underneath the skin, attached to the nerve. And it kind of constantly is stimulating, or not constantly, but stimulates for maybe a minute, and then 5 minutes it's off, and then a minute on, a minute off, 24/7. You can adjust those parameters, of course, and make it not stimulate in certain periods if you'd like, but it's the idea of it is to prevent seizures, whereas the RNS system is more to detect seizures and try to stimulate them away when they start. And then there's another option, which is also where we implant leads in the brain, called thalamic deep brain stimulation. But this is pretty similar to vagus nerve stimulation in that it's kind of just stimulating and then not stimulating, on, off, on, off. So the reason it's in the thalamus is because the thalamus is highly interconnected with a lot of different areas of the brain. And so if you stimulate there, the idea is that hopefully you'll be able to kind of keep prevent activity from synchronizing too much and getting too active and generating a seizure. So both these, vagus nerve stimulation and thalamic deep brain stimulation are really just kind of always on, meaning like on then off, to prevent seizures, whereas the RNS system is more kind of listening. It's like what we call a closed loop system, listening for seizures and then stimulating them when it detects them. Really, how do these work? Of course, there's the RNS system I mentioned is hopefully kind of just zapping seizures away, but that's not always the case, and it's tough to kind of see and prove that in practice. Actually, all these stimulators tend to have their best efficacy or effectiveness over time. And so the actual mechanisms with which we think they work is, of course, sure, make it harder for seizures to start by raising the threshold. That's what we think VNS and DBS do. Also, maybe to prevent them from spreading so far. So either if you can zap them once they start, or if you can continuously sort of stimulate when they're already going, like in vagus nerve stimulation and DBS, maybe you can prevent them from spreading so far. Maybe get them to stop sooner once they've started. That's particularly for RNS here, but also vagus nerve stimulation and deep brain stimulation. There's a magnet that the patient usually has with them or in the house, and the family member, if a seizure is started, can go get the magnet, wave it over the device, and there will be an extra stimulation delivered at that time, which is usually a little bit stronger stimulation since it's triggered with the magnet. And then lastly, brain remodeling. So we're realizing more and more in recent years, including with a lot of research projects going on at UCSF and other institutions, that the way that these stimulators may be working over time is they might be sort of slowly remodeling the circuits in the brain, particularly the circuits for epilepsy. If they're kind of constantly just buzz or stimulate a little bit here and there, the connections, hopefully between the neurons that are involved in the seizure onset zone, will get a little bit loose or just not as efficient as they were before in generating seizures. So we also call this plasticity, where you're actually changing the connectivity over time. So we think that this is more likely one of the main reasons that these stimulators tend to work, and that's another reason why it takes kind of a long time to start to see significant benefit. But we really do see a lot of benefit in patients. We can get anywhere from like a 50 to 75% reduction in overall total number of seizures for a person per month, after several years. Okay, it's not like an immediate effect. It's not like we can turn this thing on and have a great effect right off the bat, but we really do see a lot of benefit for most patients over the course of time, or at least for most patients across these stimulating devices. So yeah, that's kind of the newest frontier of epilepsy treatments. But again, we always try medicines first because it's really the lowest risk out of anything. And for the patients that remain drug resistant, it's important to at least consider things like surgery and possibly a neurostimulator if surgery is not going to be feasible. Usually we would recommend surgery if we can over a neurostimulator, because surgery, the goal of surgery is really a cure, like to cure the epilepsy itself if possible. But neurostimulators can be very helpful too, especially if surgery is not a great option for them. So yeah, a lot of different options for epilepsy, and I hope this all kind of made sense.
That was fantastic, Dr. Kleen. Thanks so much. I had a question for you. So you kind of mentioned this a lot for people who you're thinking about surgery a lot, a surgery to treat epilepsy. What are some of the tools or procedures that you go through to determine whether it's safe for them to have surgery? Like, how do you know that an area of the brain is important for that particular person?
Well, you can kind of speculate that a certain area is going to be pretty important for them just based on where it is. So like the visual cortex is probably going to have some function there, or the language cortex, a lot of people would have function there, but really it's important to confirm that, because epilepsy, especially like a seizure focus, can damage an area of the brain. It's really kind of like a scar tissue in some ways. And the function that should be there actually can leave there over time. The brain remodels itself and shifts function to other places. So we can do some tests to find out, hey, is there actually still function here or not? Because if there's not, then we could really have a chance here at removing this seizure focus and helping cure this patient. So the way that we do that is a couple things. We use neuropsychological testing. So a lot of cognitive tests beforehand to see if they are the way that they process information is what we would expect. If it is, then we would say, okay, things are probably where they're supposed to be in the brain and not moved around. But if they process things a little bit differently, then we can start to guess that maybe they've shifted things over time. To get a more direct measure of whether there's function around a seizure onset zone, we can actually use what's called stimulation mapping. And this is when the patients have electrodes implanted in the brain already and are staying with us up in the monitoring unit, or it's in the operating room itself. We can actually have the patient slowly come out of anesthesia and be awake during the surgery, very carefully and very comfortably with the anesthesiologist and the surgeon, making sure everything is nice and calm, and having the patient actually see some pictures and naming the pictures, or repeating the words that someone says, or doing other tasks that are really, really relevant. So if it's the visual cortex, you're going to show pictures. If it's the language cortex, you're going to ask them to repeat, other things like this. While they're doing this, the surgeon in the operating room, or even me at the bedside, if they're upstairs, we can stimulate the electrodes that are right around that seizure onset zone and literally produce a map of what the patient needs and what potentially doesn't have any function. There's always some sort of risk benefit aspects, because we can never prove perfectly exactly that the outcome is what we anticipate based on that, but it is actually really quite good. And we've been very successful, as many other centers have, using stimulation mapping to feel much more confident in pursuing a resection that the patient ends up having a really good outcome.
Thanks. And sort of related to that question, do you ever ablate a region in the brain instead of removing it with surgery?
It's a great point. I should have brought this up during the talk too. So you don't necessarily have to have an area sort of removed in total, like the actual tissue itself taken out, but you can use this newer procedure called ablation. And it's still kind of undergoing clinical trials right now, but we have some pretty good evidence that it works quite well, and we're using it sort of off-label in a certain way, but it's quite effective. And the way to go about it is, instead of removing an area of bone in order to get access to the brain, there's a hole that's made in in the area where the probe would need to go into. It's sort of like a lobe equipped with a laser, sort of a heating device on it, and it goes into the brain with a special, we call it stereotactic coordinates. So there's literally like a lot of amazing systems that are getting the three-dimensional coordinates of exactly where the surgeon needs to go based on the skull structure, and the probe goes in to target the seizure onset zone. Once it's there, it actually applies sort of like a little laser coring out procedure, and it ablates or renders that tissue no longer functional. And it is pretty effective for a lot of people, although it is less effective than resection, we've found and other people have found. It can actually be really helpful though when you have someone, for example, with hippocampal seizure onset zone on the left side, where their language sits just outside of that. So instead of having to go through the language cortex and remove that and have a risk of language deficits, you can actually bypass it with a laser and go in and remove, or sort of ablate, the hippocampus. And then you've spared all the language areas. In those patients, like I said, it can be less effective and their seizures may come back, but at least then you still have the option, if the patient wishes, to pursue something like resection surgery.
Great. And then why, you sort of alluded to this, you kind of talked about this a little bit in your talk, but why do you think that the temporal lobe is so often the site of seizures as opposed to other areas of the brain?
Yeah, I mean, the temporal lobe is such a fascinating thing. It's a sort of outgrowth from the brain that was not even there in lower mammals, but then it was an outpouching, and then it became bigger and bigger. And now we have a pretty sizable temporal lobe compared to pretty much all of the species. So there was a lot of needs for it to develop and to become larger and bigger. One of those is thought to be our need for language, especially advanced language. A lot of the language areas are sitting in the temporal lobe there. Also, sort of information processing sits in the temporal lobe. So this area got pretty big. And as I kind of alluded to before, it still houses our core memory machinery, which is the same sort of memory machinery structures that other mammals and even reptiles and other organisms have. It was created through evolution at some point, and that was so effective and so important that it was preserved over time as we've gotten more and more evolved. But in order to do these incredible functions like memory and pulling information out whenever we want, kind of at a moment's notice, it requires a lot of excitatory connections. It requires a lot of neurons that are talking to each other with a lot of activity. And when that happens, sometimes there can just be too much activity. And especially if there's something that happens, such as an injury, it's due to substances, due to an infection, something like that, it can make all that extra crosstalk go overboard. And those neurons will basically kind of take in way too many ions like sodium and calcium, and they'll swell up. And when they get swollen up, they can start to have other processes go on, like releasing caspases and things like this. But basically those lead to death of those cells, unfortunately. And that area then becomes scarred over tissue. Many times there's still function there in other areas of the structure. And so sometimes, we can't even remove the hippocampus because we think it, may be needed by the patient. But the worse the epilepsy gets, tends to be associated with worsened scarring out of that tissue, and then hopefully a chance to even remove it to help them.
So yeah, that's really interesting. So do you think that maybe this 3-layer older structure in trying to communicate with this kind of newer, like top of the line iPad or iMac Air, so all those connections that are formed somehow can short circuit more easily?
Kind of, yeah. And that putting it that way is kind of speculation, so I shouldn't tout that theory too much. But clearly, people have shown that the high density of excitatory receptors, including NMDA in the hippocampus, it's one of the highest densities in the entire brain. That's really associated with this whole predisposition to excitotoxicity. And then there's a huge amount of what we call recurrent synapses, or recurrent axon circuitry, where neurons in one area, particularly the CA3 area of the hippocampus, the little sub area of it, they'll send off axons to talk to other neurons, but they'll also talk to other neurons right next to them, not just the downstream structure, but their neighbors. And when you have, with epilepsy, you can get neurons in that structure, the other nearby structures like the dentate gyrus, all like over synapsing with each other, like way too many synapses. They call this mossy fiber sprouting, is one way to put it. And that, again, having one neuron talk to way more neurons than it's supposed to, if that happens across a lot of neurons, you could imagine that leads to excitotoxicity.
Okay. Next set of questions is really interesting. So, what if you have a patient that has these recurrent events that's really affecting their life, but you do all these recordings and you don't find a seizure, and maybe there's some features of the seizure that don't seem like they can be mapped onto the brain? So, like psychogenic or non-epileptic seizures.
Ah, right. And you're talking about like when we do the EEG sort of process and things in the MRI.
Yeah, how do you diagnose those, and how do you treat those
Yeah,
conditions?
absolutely. So that's a really important thing to consider in our field, because actually we have the epilepsy monitoring unit where people come in, get an EEG on, and they stay with us for a few days, sometimes several days. And the point of that is to figure out where their seizures are coming from, or what their seizures are, what type they are, but sometimes even if they are seizures. So about a quarter of the patients that come to our epilepsy monitoring unit are diagnosed with non-epileptic seizures. And this is sort of a psychiatrically driven symptom where it looks for all the world like a seizure. The person may have convulsions, they may have certain movements of their face, their arms, or other experiences, or other symptoms that we see, but it's not driven by abnormal electrical activity. And so the stay in the epilepsy monitoring unit is really important because they have the EEG on, and when they're going through one of their typical episodes, typical for them, they, we can see normal brain activity during that time. So really that's diagnostic for non-epileptic seizures. So the treatment for non-epileptic seizures is very, very different than the treatment for epileptic seizures. Again, epileptic seizures being seizures or abnormal movements and behaviors and such that are driven by abnormal electrical activity in the brain. So for non-epileptic seizures, these are events that tend to be driven by sort of deep-seated disturbances with mood or anxiety or stress, sometimes prior trauma. Oftentimes it's really terrible things that have happened to someone in the past, whether it be distant past or recent past. And it's sort of a way for the body, the mind-body connection to produce a way or to cope with it. But it's not exactly a healthy way because it comes out in these events that look like seizures, epileptic seizures. The person may go to the emergency room, have 911 called for them, and they may get put on a lot of anti-seizure medicines, which are really only going to cause them side effects and not help them. So if we can help diagnose them with non-epileptic events, we can then get them hopefully down the right treatment track, which is actually finding ways to work on mental health to visit these deep-seated sorts of disturbances in mood, prior traumas, other things that can be driving these non-epileptic events. One of the biggest things we tend to recommend is cognitive behavioral therapy. It's a type of mental health therapy where we focus mostly on what deep things are driving these in the background, and then you focus on what the triggers are and what the contexts are in which these events occur. And then you focus on how to sort of divert yourself from going down roads where it leads to these sort of non-epileptic spells, and trying to find other ways to cope and to deal with these deep-seated symptoms that are not non-epileptic in more healthy ways.
Yeah, I think it's an interesting field. And luckily, we have an expert here on campus that luckily is able to join a talk recently, Dr. Vivek Datta.
Yeah,
He
excellent.
specializes in this group of disorders that we're really learning a lot more about. So functional neurologic disorders and PNES, or psychogenic non-epileptic seizures, are a part of FND. And it's just fascinating what we're learning about the different circuits in the brain that are affected, that are not your classic hippocampal temporal lobe, but maybe higher up, like temporal parietal junction, or deeper within the brainstem. So it's a really cool field. And unfortunately, not one size treatment fits all right now, it seems like. But yeah, CBT is definitely a mainstay. And this patient, or one of our participants, mentioned a dynamic neural retraining system, which I've heard about, but I don't think that there are any studies. Do you know of any studies, Dr. Kleen, on this?
Is this under the realm of sort of biofeedback, or is this more of a?
I think it's a form of biofeedback for targeting the limbic system.
Okay, gotcha. Yeah, if it's under the biofeedback umbrella, people are finding increased effectiveness for some of these biofeedback approaches, and there's a lot of companies that are kind of up and coming on, finding ways to be able to look at your own brain waves and to try to learn over time how to kind of modulate them. And for epilepsy, the idea would be if you notice rhythms or sensations that might be associated with maybe impending seizures, that you can kind of retrain your brain on how to divert away from them. But I think right now the evidence is not quite there in terms of recommending this on a mass scale, but it seems to be showing some progress and some hopefully future implications, because that would be great if it's another, especially non-medical option, where the person doesn't have to take another pill and can learn other ways such as even relaxation techniques to kind of use their own biofeedback to tone things down. I hope that's what this particular therapy is under the umbrella of. So I'm speaking about something totally different. I'm glad you mentioned Vivek Datta too. He's a really great provider, and non-epileptic seizures, just to kind of mention a couple of more things, there's some really crucial points about them. They are very real. Unfortunately, some patients are told that they're not, or they're fake or something like that. They're absolutely not fake. They're a real psychiatric condition, and they need, so they're real. They cause a lot of impact on someone's quality of life, and they also can be treated. So those are important things we really try to emphasize to patients.
Great. Well, thank you all for joining us.